Hello, I'm Lisa Martin from HORIBA Veterinary, and I'm delighted to welcome you all to this continuing professional development webinar, the next in our ongoing series. We're very pleased to have you join us. All of our previous CPD content on a wide range of veterinary subjects is available to watch back at any time in the support section of the HORIBA Veterinary website. Firstly, I'd like to introduce you to our speaker, tell you what to expect from the webinar, and a little bit about HORIBA. We're very pleased to be working today with Amanda Paul, RCVS recognised and European specialist in small animal internal medicine, currently head of the Medicine Service, Hamilton Specialist Referrals, Buckinghamshire. She's speaking on and answering questions on respiratory disease in dogs and cats. Amanda completed a Bachelor of Science at the University of Sydney and then Veterinary Studies at the University of Queensland, Australia. She initially worked in a mixed practice with a large greyhound and breeding clientele and a quarantine service. After completing a certificate in veterinary acupuncture, she transferred to small animal practice in Sydney, completing her export certification and a Masters of Small Animal Veterinary Studies through Murdoch University. An interest in specialist practice led her to work in emergency care at one of Sydney's specialist centres, where she also became a member of the Australian New Zealand College of Veterinary Science after examinations in small animal medicine. Amanda then completed a residency in small animal medicine at Murdoch, becoming a diplomat of the European College of Veterinary Internal Medicine and achieved a Masters in Respiratory Medicine in dogs. In 2016, Amanda moved to the UK and into referral practice, working as a clinician and later as leading a medicine team. In 2024, she joined Hamilton Specialist Referrals as head of their medicine service. Amanda enjoys all aspects of medicine in management of acute, chronic and interventional medicine, particularly with a respiratory focus. She continues to contribute significantly to the profession through the provision of CPD and specialist training, scientific literature, and via the colleges of which she is a member. HORIBA Veterinary sits within HORIBA UK with expertise in scientific testing, mass flow controllers, automotive testing, and air and water quality testing. HORIBA Veterinary and HORIBA Medical are a well-established provider of laboratory diagnostic instruments. We work with reference laboratories, academia, and general practice and referral settings. Our veterinary product range currently includes handheld meters running single parameter tests, higher capacity, user-friendly, automated chemistry and hemostasis systems, and the first fully integrated in-house PCR testing system. Here's a brief introduction. Our LaquaTwin handheld meter range works in seconds on small sample volumes for individual parameters, including ionised calcium, pH and electrolytes, and can all be used patient-side. HORIBA offer benchtop systems for clinical chemistry testing, from occasional use to large reference laboratory throughput, offering highly cost-effective solutions and bespoke profiles alongside the facility for esoteric testing. We also provide instruments for immunoassay and blood gas testing. The Pocket Central PCR Analyzer is a unique, easy-to-use benchtop system which integrates seamlessly with your current lab provision. Now within reach of all veterinary settings, each step of the PCR process is fully automated and can be run by any trained member of the practice team 24 hours a day. Results are available in under 2 hours, speeding up diagnosis times, informing prescribing decisions, including responsible use of antimicrobials and aiding patient and site management. The Pocket Central test range includes over 190 assays, enabling fast and easy testing for bacteria, viruses, parasites and protozoa across a range of sites for small animal, farm, equine, poultry and aquaculture work. PCR testing for all species is now accessible to everyone. Should you have any questions, please pop your query into the box on the screen and we will cover as much as possible at the end of the webinar. If you're watching live and would like HORIBA to issue you with a certificate of attendance, please provide your name and email address in the chat box and we will send your certificate on in the next few days. You'll also have our contact details at the end of the webinar for any further queries or if you're watching back. The event recording will shortly be available to view via the HORIBA Veterinary website, and you'll be sent details to enable access for you or for any colleagues. So now I'd like to hand over to Amanda for her presentation on respiratory disease in dogs and cats.
Hi, thank you for joining us as we kind of take a journey through infectious disease in dogs and cats. It's an area I kind of feel we often under-recognize. We often sort of see infectious tracheitis, bronchitis, aspiration, or bronchopneumonia, but so many aspects or diagnosis of respiratory disease are kind of under-recognized or not diagnosed or just don't even cross our radar at the time. So our field of diagnostics and our understanding of respiratory disease is really expanding, and there's a lot of room to expand within veterinary science. So we can do a lot more in general and referral practices than what we used to be able to do. So what we're going to do today, and effectively as we watch this pug, you can see that it has severe inspiratory dyspnea, and it's obviously in an oxygen cage. We accept, okay, it's probably one of our BOAS dogs, but when you look a little bit closer, you can see that this dog has quite a marked expiratory push, and suggests we need to look further than just considering BOAS as one of our diagnostics. There's a multifactorial disease that's in play here and likely a pulmonary component. And it just reminds us that infectious disease is not just independent, but part of a larger presentation and conundrum. So we're kind of going to walk through a little bit of a reminder of the immune system, its dysregulation or failure, because it's really entwined in the establishment of infectious lower airway disease. And then we're going to look at infectious causes of airway disease, which we see commonly, and some of them are really less common, but are starting to sort of creep into our radar, and maybe some of them are starting to emerge in the UK. And finally, we look at the use of PCR and its use in respiratory disease. So the immune system it's this complex system of interactions, and you look at this diagram and you get really nervous. And I think when we're in vet school, many of us were pretty overwhelmed and just wanted the subject of immune disease or immunity to end. And as a resident studying to be a specialist, I just wanted to sit the exam before someone else identified another cytokine and changing the face again of how we think about the immune system. So when I really sat down and tried to work it out, by far the most reasonable interpretation to my mind was a text that was written where I took some of this diagram from by Somprayarak, and that's an anatomic specialist who sort of put me onto that. It kind of describes the immune system as a military operation and a battlefield, and it breaks down the interactions into kind of understandable objectives and attacks. You know, we think of the innate system or complement system as early defense, and this system reacts to triggers and danger and alerts the adaptive system. And it's made up of about 20 odd different proteins that destroy invaders. Basically, the body is launching grenades and smart bombs. Macrophages and neutrophils act as like advanced foot soldiers, and a second line of defense, basically taking down the enemy before it can advance en masse. And they send out signals alerting the troops to kind of gear up for battle. Dendritic cells within the system act kind of like the coast watchers of World War I and II, or listening post, collecting information on size and location of attackers, and that they convey that intelligence by signals. So if you consider virgin T and B cells like military bases, say Army and Navy, where the generals are making decisions, they then activate and send out units to hunt and kill the enemy. So activated T cells or T cytotoxic cells, or activated drones and mission specialists like B cells, activated B cells that paint the targets with antibodies for destruction, that activate macrophages and smart bombs. So these signals from these activated units recruit help by sending out these cytokines and signals calling for aid. So any kind of failure or overwhelming of defenses leads to infection and progressive disease. And our respiratory system is a microcosm of immune or military responses. And what's more, while needing to provide a proportionate response, i.e., maintaining the appropriate half-lives of everything that's going on, it fatigues with age, and sometimes while it needs to allow the body to function as business as usual, it doesn't work quite as well as what it should. So there needs to be cooperation from the innate and the adaptive system, and we need to learn from experience and create records so that these repeat invaders or repeat infective organisms, that we can recognize them straight away. And when we get a failure of that adaptive system, that's when we're more likely to be able to allow any kind of infection to take a foothold before we're able to mobilize our neutrophils and macrophages and basically target the invaders with antibodies. So our respiratory defense system basically starts in the nose with the invaders and anything from dust and noxious gases, allergens or pollutants. And the body has basically evolved these physical host defenses, much like parapets or ramparts and moats, to protect itself, including mucus that kind of traps the invaders and slows their progress, multiple angulated branches of the immune system which make the invasion more challenging. And it's much like those kind of branched trenches along the Western Front. And then they act as a sort of first line of defense in allowing the innate immune system to take hold. So it's not uncommon in many cats and dogs that are referred for investigation of nasal discharge, and where antibiotic coverage has been the first provision. The respiratory system has really been devised to, from the nose to trap microorganisms. And so its job is to stop them getting lower into the respiratory system. So often a positive swab to a bacterium from the nose is not always pathogenic infection. And it just may be that the host defenses of the dog or the cat are actually working, which is an entire focus for a whole other discussion. How do you interpret nasal swabs? So to wrap up the innate and adaptive immune systems, we can see that the respiratory tract uses more physical as well as innate immunity. And as we move down through the trachea, our coast watcher or listening post starts its role with the dendritic cells signaling B and T cells, our bases, to activate and attack all those bacteria, viruses, parasites, fungi, protozoa along the way. Oh, there we go. Next slide. So I'm going to start out with this bacterial lower respiratory tract infections. And bacterial respiratory infection is probably the most recognized infection of the lower respiratory system, and it's the most common sequela is bronchitis or pneumonia. The role of primary bacterial infection in initiating bronchitis hasn't really been determined. It's more common that chronic inflammation of the lower airways results in secondary bacterial infection. And in cats, it's not uncommon that the refractory cough or deterioration that occurs with feline bronchial disease often has Bordetella and Mycoplasma that are actually isolated. In dogs, clinical signs of chronic bronchitis are usually just a cough of 2 months, greater than 2 months duration, without signs of real respiratory distress or tachypnea. And so bronchiectasis can be a sequela to bronchitis. Thoracic radiographs are usually normal or may have some interstitial or peribronchial infiltration. Bronchoalveolar lavage may have an increased mucus and neutrophils in both dogs and cats, and bacterial growth is often minimal if quantitative cultures are performed. In cats, bacterial colonization is often even lower, which really reflects contamination rather than pathological disease. Mycoplasma, whenever we see that, it's always worthy of consideration. It can be found in healthy airways of dogs, not in cats. It can degrade neural endopeptidases, and it kind of prolongs the effect of substance P, which acts as a bronchoconstrictor. So mycoplasma is quite significant in cats. Bacterial infection and repeat bacterial infection damages airway epithelium, which causes chronic inflammation. And we can thus get this bronchiectasis that can be both a cause and a result of infection. Bordetella, it can be a primary and a secondary pathogen, and interspecies transmission can occur. Widespread resistance to cephalosporins and ampicillin exist, and this probably, with indiscriminate use that we've used to manage infectious tracheitis. So we really need to be careful when we're considering an antibiotic if we've got Bordetella, to avoid antibiotics that achieve low concentrations in airway tissues and fluids. And amoxicillin clavulanic acid is one of those, or Simulox, or whichever other trade name you use, and parenteral gentamicin as well too. So penetration of antimicrobials into airways and into pulmonary parenchyma is really favored by lipophilic and low molecular weight drugs. So drugs entering bronchial secretions such as TMS, trimethoprim sulfonamide, fluoroquinolones, clindamycin, erythromycin, and doxycycline probably all enter in the highest proportion into the airways and are maybe worthy of consideration first. Many bacteria cause parenchymal inflammation, and bacteria enter that lower respiratory system primarily by inhalation of or aspiration of aerosols, so they overwhelm those physical ramparts and the innate defenses. Oropharyngeal flora, foreign material, aspiration of gastroesophageal contents, or hematogenous spread of extrapulmonary infection. Normal clearance, and so normal, immune response, we have clearance mechanisms that are effective until bacteria are greater than about 100 million, organisms per mil. So that's pretty significant. Or if gastric acid is currently aspirated, so that always doesn't help us. So infection really depends upon the virulence of the organism and the concentration and the host resistance. And clinical conditions that really predispose the dog and cat to bacterial pneumonia, things, those metabolic disorders, dysphagia, vomiting, regurgitation, immunosuppressive therapy, Cushing's, uremia, DKA, neoplasia, even just reduced consciousness, laryngeal paralysis, all of these can predispose to these bacterial lower respiratory tract infections. So what are the more common bacteria that we actually see? Most bacteria from the trachea and the lungs are identical to those in the oropharynx. So most bacterial infections are opportunistic invaders, and this can really cloud our interpretation when we get culture results back. And so I'm just going to pause briefly just to remind, what predictive value is, because it's really important to consider when we're making our lower respiratory tract infection diagnosis, well, as with any diagnosis. So that predictive value is determined by the test characteristics, so by the sensitivity and specificity, and importantly on the population which we're actually selecting our test for. So the practice of testing patients with a low likelihood of disease can generate more false positive results than true positive results. And so we get a misdiagnosis, and then we're using inappropriate antibiotics. So the positive predictive value is the probability of a patient who has a positive test result of truly having a disease, and vice versa. The negative predictive value is the probability that patient has a negative result, doesn't have the disease. So any assay with high diagnostic sensitivity improves that negative predictive value, and one with a high diagnostic specificity will improve the positive predictive value. So when we look at it, bacterial pneumonia is a lot more common in the dog than the cat. Bordetella and Streptococcus zoepidemicus are often primary pathogens. Gram-negative infections, which are the ones, gram-negatives are actually written in red on the slide. They're often the predominant bacteria that we see, and with mixed infections commonly, but sometimes we can actually see a single bacterium, but typically more often our culture results are showing us mixed infections. Streptococcal infections can have a really varied virulence, but strep pneumonias can be associated with hematogenous spread to multiple organs. So that's something to always keep an awareness of if you get a streptococcal diagnosis. E. coli are usually part of aspiration, and similar to streptococcus can disseminate throughout the body as well too. So they can also colonate after viral infection or even after long-term antibiotics or glucocorticoids. And so it's not really pathognomonic for any particular causation of pneumonia when you get an E. coli that's actually cultured. Well, so in cats, oh, I'll just jump back one, hopefully. So in cats, less is realistically known about bacterial pneumonia in cats compared to dogs. Cats often don't show clinical signs, and they can really lack the hemogram changes that you see in dogs, and sometimes really lack those thoracic radiograph changes as well. In fatal pneumonia of cats, the most common bacteria we see are Streptococcus canis, Pasteurella, E. coli, Fusobacterium, Pseudomonas, Bacillus, Enterobacter, Enterococcus, beta hemolytic streps, and Bordetella as well. And Bordetella can be significant, a really significant cause of mortality in pneumonia in kittens, but it's worth pausing on Pasteurella. Pasteurella is part of the normal flora of the nasopharynx, but any kind of concurrent viral illness that can cause migration, it can cause migration of the Pasteurella to lower airways. And Pasteurella forms adhesions within the lower airway and has this kind of polysaccharide capsule which stops phagocytosis. So it really tries to overcome our innate and our adaptive immune system. And so the bacterial proliferation of that results in this sort of influx of inflammatory cells and cytokines, and you can get this really marked fibrinopurulent exudate, and it's a really slow pneumonia to resolve, and it's not uncommon to see with abscesses and pleuritis as well. So cats, things are less well known, but whenever I sort of see Pasteurella, I know that I'm in for a bit of a fight with this infection. Now, probably one of the most common advice requests we get in referral medicine is often with respiratory radiographs. They can often be quite challenging to interpret. In dogs, the diagnosis of bacterial pneumonia is, we often make that diagnosis based on, a suspicion from the clinical history and clinical examination. In our hematology, we might see an inflammatory leukogram, and then thoracic radiographs and microbial and cytologic, examination of BAL is always really helpful. In cats, as I mentioned earlier, physical exam, thoracic radiographs, the CBC, they really may not be abnormal. And so when we look at these radiographs, bronchial patterns are really distinct, from interstitial and alveolar patterns. They have this thickening, of the larger conductive airways. The radiograph, opacities, you see these ring-like donuts, which you can actually see on this radiograph here. And you can sometimes get these parallel tram lines, and they stand out from the interstitium. Sometimes you get a peribronchial cuffing, which are kind of indistinct opacities that surround the airway, and that really exacerbates this bronchial pattern. And the real primary differentials for a true bronchial pattern are chronic lower airway disease, so an allergic or a chronic bronchitis, any kind of infectious respiratory disease complex, so that we would see, or the CIRDCs that you see reported, and parasitic infection. And one thing that's worthy of mention here is diarrhea filarias, or heartworm, because heartworm is making its way across to us actually being able to see it in the UK. Interstitial patterns, indicate some kind of disease or disruption of the interstitium. So the real characteristic findings here are this increased opacity of the lungs, which really tends to obscure the blood vessels, or blood vessel margins, and that may be due to edema, pus, blood, or any other material that you might actually see in the lungs. And they can be structured or unstructured. So the distribution of unstructured interstitial pattern is probably more suggestive of certain differentials than the appearance of the pattern itself. And that can be like pulmonary edema or pneumonia. A pulmonary thromboembolism could cause it, PTE, hemorrhage, or fibrosis. And our differentials, when we consider structured or more nodular interstitial patterns that are kind of round or ovoid soft tissue opacities, might include neoplasia or fungal disease, parasitic cysts, bulla, or you can sometimes see them with those little osteomatas or granulomas. Our alveolar pattern is, it's more severe than that interstitial pattern. And so you see that increased opacity, which kind of stands out here, which completely obscures the blood vessel margins. So air bronchograms with lobar signs, you might see those present. And the differentials are really sort of similar to what you'd see for an interstitial differential that we just mentioned. So you can, that kind of gives you an indicator. And I know, looking at radiographs can sometimes be quite challenging because they can have mixed patterns, that appear as well too. But, alveolar patterns, when I look at it, I often sort of think of a tree leaf, and that sort of helps me with how I'm looking at making my diagnosis along the way. So definitive diagnosis, to get a lower bacterial, lower respiratory infection, you really want to obtain microbiology and cytology, and you really want to bypass the oropharynx, because, as I said, so much of the oropharynx can be a cause of what we see causing the pneumonia. So we want to make sure that we're not complicating our diagnosis. So passing a tube, as you can see here, through an ET tube and doing a blind BAL if you're looking for something to culture, or going down a bronchoscope as well. Blood cultures can sometimes be useful. They don't always represent what's happening in the lungs, and sometimes in large dogs, you can also do transtracheal aspiration that people get very nervous about, but it bypasses the oropharynx. Probably by far the most common that I use would be an endotracheal wash or a BAL. And sometimes if I've got a really consolidated lung lobe, I don't have a fear of actually doing a fine needle aspirate into the lung, because that bypasses the oropharynx as well too. And I might either inject that onto a culture swab or into a culture pod itself. The big tick to remember too is many times you see people doing mycoplasma PCRs, and that doesn't always correlate with infection, particularly in the dog, because it can be a normal respiratory flora. Anaerobic bacteria, can sometimes be associated with pneumonia, particularly if there's a history of aspiration, or there's a grass seed or grass-borne foreign body. Anaerobes are quite often associated with that. Some commercial laboratories do have difficulty culturing these, and so may not provide antimicrobial susceptibility data. Though most antimicrobial agents that have an anaerobic spectrum are basically often used and should be fine to use. Metronidazoles if you do have an anaerobic infection, when you can't sort of rely on when you don't have an anaerobic culture to be able to look at. Aspiration pneumonia, often multiple bacteria, as we mentioned at the start, are often cultured, and it's really difficult to determine what is sort of involved with the continued inflammation and what may be having a bit of a bystander effect. So it's when you get when you get a comment coming back from the clinical pathologist that sort of says there's few or rare organisms, or it's sort of a mixed culture, or there's possible airway contaminants, things like bacillus or coagulase negative staphylococci, I'm always just using a little bit of caution in, do I really need to target these bugs? Are they contaminants? Are they bystanders? Are they truly part of the underlying cause of all the inflammation or the sickness the aspiration pneumonia that's being experienced? So another thing to always consider too is if you are using an endoscope to collect a lavage specimen, you can have, endoscope-related contamination. You should always consider that, particularly if you get unusual species such as Serratia, or, and I always struggle to say this, Stenotrophomonas. Any of those would suggest you probably have some sort of contaminant that's occurring. So when selecting, antimicrobials, I think it's important that we're using caution these days. The European Medicines Agency Antimicrobial Advice Ad Hoc Expert Group, the AMEG group, they've really categorized antibiotics for use based on potential consequences to public health and what we're seeing with increased antimicrobial use, resistance when we're using them in animals, and how we should use them in veterinary medicine. So they've sort of classed them with prudence, caution, restrict, and drugs to really avoid. And selecting it here, these are the typically used antimicrobials that we'll often have used with respiratory infection. So for bronchitis, the antimicrobial group recommend doxycycline. So that's a base to start with. For a simple pneumonia, they're generally recommending an antimicrobial like ampicillin or Ampicillin sublactam, or a first generation cephalosporin such as cefalozole. I always use cephalosporins somewhat cautiously with pneumonia because of their penetration. So for me, my preference is the ampicillin basis. So when we have a pneumonia with sepsis, we're probably going to be using a fluoroquinolone and a drug with gram-positive and anaerobic type spectra, such as clindamycin or ampicillin. So that's more a pneumonia with sepsis. And if Bacteroides is cultured, using metronidazole, because clindamycin will not be effective against Bacteroides. So all those listed, antibiotics that we use with infectious respiratory disease, most of these fall into the use with caution group. But as I mentioned previously, there's penetration of these drugs into airways and pulmonary parenchyma is really favored by those lipophilic, low molecular weight drugs, such as TMS, fluoroquinolones, clindamycin, erythromycin, and doxycycline. They have the highest proportion of penetration. Of all of these, doxycycline, lincosamide, the macrolides, cephalosporins, and aminopenicillins, they're time-dependent antibiotics, and they exert their optimal bactericidal effect when the drug concentrations are maintained above the minimum inhibitory concentration. So typically these concentrations are about 2 to 4 times the MIC throughout the dosing interval. So for these agents to have higher concentrations, you don't get a greater kill of organisms. So they tend to have any kind of minimal to no post-antibiotic effect. Whereas concentration-dependent antibiotics, such as the aminoglycosides and the quinolones, they achieve their best rate of kill with increasing levels of the drug. So in addition, they kind of have an associated concentration-dependent post-antibiotic effect. So this is where their bactericidal action continues for a period of time after that antibiotic level falls off below the MIC. So for this group of drugs, concentrations at least 10 times the MIC are needed for their optimal antibacterial effect. So if you're using a lab that provides you MICs and you're looking for selection of the drug for a concentration antibiotic, dependent antibiotic, you have a look at those MICs to determine, is there at least 10 times the effect? So that's going to optimize how your antibiotic is going to work. A third kind of category does exist, which is the bacteriostatic, and they're mainly time-dependent antibiotics that do have a prolonged post-antibiotic effect, and that we poorly kind of recognize this. And it does happen with clindamycin, the tetracyclines and the erythromycin. But at least there's a guidance as to what we're using first off before as we get our culture results back. So recapping, we always are going to look for other underlying disease. Many of these dogs and cats have predisposing disease. Laryngeal paralysis and collapse, BOAS, and in the case seen here, which you can see is having an upper airway exam on the left-hand side, laryngeal masses are not uncommon, and these are often referred for obstructive airway breathing. We're sort of now also a lot better at recognizing aerodigestive disorders. So there was recently, a series of articles that were published by Megan Grobman, and she's really highlighted this. Dogs can present for a cough without any evidence of alimentary disease, but it is in fact present. So in one study, and it was only about 30 dogs, but in this study they did fluoroscopy, and they identified that there were abnormalities in 81% of dogs, and in 8 dogs there was no respiratory disease that caused the cough at all. It was purely due to actually gastrointestinal disease or reflux or regurgitation. So esophageal hypomotility, reflux, megaesophagus, laryngeal obstruction or dysfunction are all intimately linked with respiratory disease and cough. So as you see on this slide, there's kind of a progressive clearing or loss, of hyperemia in the tracheobronchoscopy, which is at the top of the slide, and, esophageal ulceration and fluoroscopy. And down the base, we're sort of seeing kibble that's being used for a swallow study. And if you look at the P, which is particle, that's actually a piece of dog kibble that's actually appearing in the dog larynx as opposed to going down the esophagus. In the other fluoroscopic image, there's a liquid phase or a BIC sign, which is indicating reflux. In the top, what it tries to show is this dog has actually had reflux that he's aspirating, and as we pass down from the top of the esophagus, we see this marked hyperemia that tends to dissipate. And if you're really looking right from the start with some of the endoscopies, if you're performing them, in dogs that have reflux, you may see this, what might be suggesting that there is some degree of gastrointestinal disease that might be associated with these particular, with coughing in this dog. So a commonly asked question once we've got a bacterial pneumonia is, how long do we treat? And there are a number of recommendations that are out there. Textbook dogma, talks of this prolonged treatment and treating beyond radiographic resolution, which in itself may be well beyond what's required and potentially lead to resistant bacteria and a lot of financial burden for the owner. The antimicrobials, working group, they suggest an initial 2-week course of treatment and then possibly extending based upon radiographic and the clinical presentation of the dog. What I have found useful most recently was there was a paper that was published that kind of assessed the acute phase inflammatory markers. And one of the reasoning is that we often have this clinical resolution prior to radiographic resolution of the disease. And this study really demonstrated that concentrations of C-reactive protein were positively correlated with radiographic severity of pneumonia as assessed by a radiographic score, which was TRSS at the base of the graph. So this thoracic radiographic severity score was a group of radiologists that looked at radiographs, scored them, came up with a list of what was the most severe pneumonia, what was the least severe, and then was correlated to the C-reactive protein. So these use of these acute phase inflammatory markers, I've been using that because it reduces the times that I have to either re-radiograph or resedate a patient. It doesn't really specifically point to a target time or when to cease therapy, but if I see a CRP that's dropped down and it's sort of sitting there at 10 or 15, the likelihood is my radiographic score is going to be about 1 or 2. We know there's a lag effect of a couple of days before they improve. So I'll be using CRP because it's a little bit more, it saves a little bit of money for the owner and it helps guide me as to when I'm actually going to stop treatment. So that's kind of some of the information that's out there at the moment. While we're on bacteria, I'm going to mention leptospirosis because we certainly see it. It has a significant zoonotic, zoonosis, and we see it a lot more in herding dogs, hound dogs, those kind of working dogs, and those mixed breed. But any dogs that particularly like to scent or come into contact with infectious rodents, are commonly seen. We don't see lepto quite so commonly in cats, but they do come into contact with leptospires that are excreted by our wildlife. We know that they like to inhabit this, stagnant, slow-moving water, and it tends to be sort of neutral to slightly alkaline pH, and they kind of prefer a temperature between 0 to 25 degrees. The incubation time for leptospirosis, which is really important for us to note in the history, is roughly 7 days. And so while most people will recognize that there's renal and hepatic disease, pulmonary disease is becoming more frequent, and I think often a sequelae. So we might be treating for renal or hepatic disease, but then we're sort of dealing with the lungs as well, and we should recognize that. So the disease that we get with leptospirosis really depends upon the serovar and the host susceptibility. You can get tissue edema, vasculitis, and they can be really, really rapid in some of the more severe infections. And you get these real significant endothelial infections and hemorrhagic manifestations. So the lipopolysaccharide that the leptospire has is really potent activator of macrophages, and it stimulates secretion of interleukin-1, one of our cytokines, and interferon, and that really sort of augments that killing capacity. So the macrophages that secrete TNF-alpha and interleukin-10, they also play a role in inflammation, and we get a marked platelet activation, neutrophil adherence, and then we get all these hemolysins excreted that cause tissue damage. So acute lung injury really occurs as an effect of the toxins from the organism on the pulmonary tissue, and we get a lot of fluid that's exudation into the lung, and that really results from the vasculitis from the leptospirosis. And so we can see these kind of cases or leptospirosis that present with this acute severe pulmonary hemorrhage, and it's also not uncommon to see anemia at the same time. So in a bit of an older study that was published in 2010, surprising how fast time has gone, a German group really found that the severity of the dyspnea correlated with the percentage of the dogs that survived lung injury due to leptospirosis. So 67% suffering from severe dyspnea in this particular study had to be euthanized because of respiratory disease. So if you're considering that, you know, one of the differentials for a pattern like this, or to be associated with leptospirosis, why is the dog not doing well? Why is it not breathing well? Why is it hypoxemic? You should certainly consider whether it's actually having hemorrhage or an acute lung injury associated with the leptospirosis. Of the dogs in this particular group that actually had acute lung injury with leptospirosis, about 60% of them had thrombocytopenia, half had anemia, and about 70% had a leukocytosis. They had prolonged APTT, and about a quarter of them had prolonged PT. They all had effectively an increased serum creatinine and urea in about 88% of these patients. So not all of them showed, you know, significant renal injury. And only about 78% of them had increased ALT or ALP. So it's definitely worthwhile considering that when you see leptospirosis, it's really a generalized and systemic, a systemic disease. So any dog that you're evaluating for AKI, I would consider leptospirosis, and particularly when there's evidence of pulmonary hemorrhage or hepatic dysfunction. In getting to the diagnosis, and I pause here because it is something that is seen commonly in the UK, you know, getting a diagnosis based on a single positive MAT test is really not recommended. So you shouldn't rule it out either on the basis of a single negative test, especially if the lab that you're using uses a limited number of serovars, so only 6 or 7 serovars. Realistically, seroconversion, basically a 4-fold increase in the titer, occurs, you know, as early as 3 to 5 days after dogs come in to be seen, but basically an interval of 7 to 14 days is recommended to do, you know, convalescent and acute and convalescent titers to be sure of your diagnosis. So that 2-week gap to follow up and make sure that you're using paired samples. When you use paired samples with an MAT, you get about a sensitivity of about 100%, and the specificity ranges from about 70 to 100%. So a single acute MAT has only about a 50% sensitivity while the antibodies are being, you know, produced. So it doesn't really exclude a diagnosis. And I really, one thing I just always sort of highlight, if you're going to run a PCR for leptospirosis, really run this prior to the use of antibiotics, because you can get false negative results if you've started your antibiotics before you actually run that PCR. So while the details of leptospirosis are kind of out of the realm of today's presentation, you know, there are lots of consensus statements that are put out there, and it's definitely a consideration for any kind of acute lung injury infection that you may actually see. As in terms of treatment, you know, for pulmonary leptospirosis, it's pretty much the same for renal hepatical disease, but you're most likely going to need some degree of ventilation for these patients. With its bleeding, you may be needing to use fresh frozen plasma or other blood products as well. There have been things tried in people, but we really haven't seen efficacy or really haven't investigated them in detail in dogs. So a lot of it's more symptomatic in terms of how you go ahead and manage them. So protozoal pulmonary infections, that is our next place that we're going to stop along the way. And protozoal pulmonary infections really should be considered in dogs and cats. You know, of these, toxoplasma is probably the most frequent. And with pet passports and pets being adopted from European shelters, and even environmental shifts, that they're leading to an expanding range for the vectors that carry these diseases. Other protozoans such as Leishmania, less so Babesia, and probably a little less so even, you know, hepatozoonosis. These are infrequently identified, but the canny practitioner can really latch onto them and find that these can be a cause of pulmonary infection. While Leishmania really relies on the vector of the phlebotomine sandfly, which is in those Mediterranean areas, as you can see on the map there, it's really steadily becoming a more commonly asked question on how to manage these cases. And the tick, Rhipicephalus sanguinis, the brown dog tick, which is a vector for Babesia, hepatozoanosis, Ehrlichia, these can often be found together as co-infections as well too. So of the protozoal diseases, often the clinical signs are recognized, first that we're probably more commonly known for, but they can be associated with respiratory disease. In cats here with toxoplasma, pneumonia can often be secondary to fever, anorexia, weight loss, and they can all happen. Toxoplasma can sort of happen. Toxoplasma pneumonia often can be associated with hepatitis, cholangiohepatitis, and neurodeficits. And when we kind of consider our initial immune story, interferon gamma, which dependent cell-mediated immunity, and humoral factors are really important for resistance. And so that, that immunity is that main mechanism defense for the control of the Toxoplasma gondii infection. And it also prevents latent infection from becoming reactivated. So in cats, we lose our complement as it's not really activated to prevent Toxoplasma infection. But when we do see Toxoplasma, particularly in cats, they often have these really harsh bronchovesicular sounds that you can hear it. So it's hard to pick which one is more, which one's more focused, the dyspnea or the tachypnea. But in every one that I've found, I've seen it a lot more commonly in cats than dogs. In dogs, it tends to be more of a neuromuscular disease, but you tend to see these diffuse, harsh bronchovesicular sounds. So there are a number of different ways you can achieve the diagnosis of toxoplasmosis, and you can see this is a cat here that was published in the Australian Veterinary Journal with toxoplasmosis. Laboratory indicators are generally fairly non-specific, but the radiograph here is an 11-year-old cat, and the major abnormality for this actual cat was this diffuse bronchointerstitial pattern. And there was a small volume of pleural effusion, which you can see on the right-hand side. What was done here was there was a diff-quick cytology, and diff-quick cytology can sometimes be really, really useful in picking up toxoplasma, which you can see on the slide. And sometimes picking it up in stool samples to identify the oocysts as well. That really builds a diagnostic picture. But probably the most frequently used diagnosis is serology or PCR of the tissues and fluids. And so there's a lot more molecular testing that we're actually now doing for toxoplasma. Once infected, if the dog or cat is pretty much infected for life. I think we're all pretty aware of that. And so we get this long-term humoral response. So high IgG reflects that continued presence of the toxoplasma antigen. A positive IgM with an increasing fourfold titer basically says there's been a recent infection, but the oocysts are not specifically shedding. So some cats will have a prolonged IgM. Some really don't develop a high IgG until about 6 weeks after they've been infected. So if you're suspicious of it, it's sometimes worthwhile revisiting and re-blood sampling and re-looking at the IgG. And sometimes, the importance too is I've had cats referred for toxoplasma that have IgGs of 1 to 30,000, but it has been documented that you can sometimes get these 1 to 30,000 6 years, after you've originally had the detection. So they can hold some cats can hold quite high IgG titers for quite a long period of time. Most cats, once they've been exposed, they're probably going to be positive with an IgM titer about 2 weeks after infection. But some cats don't really have stable IgM until about 4 to 10 weeks afterwards. and up to 20% of cats won't even develop, you know, an IgM detectable titer. So that can be sometimes a bit of a challenge. Most common antibiotics, clindamycin. I probably use clindamycin more frequently than TMS. And I've been quite successful with doing that, but you can use TMS. Pyrimethamine has also been used in addition to folinic acid, which corrects bone marrow suppression if you go ahead and use that. Again, I'm not going to spend too much time on that. Leishmaniasis. So around 6% of infected dogs do develop a cough. So I'm going to bring leishmaniasis up because we are getting more and more infection, more and more questions as it comes across, or dogs come across on Pet Passport, or have come from Mediterranean countries, Cyprus, or have been rescue dogs. And so, you know, we're seeing it with pet travel. You know, most of us will sort of, when we see it, will recognize the renal and the skin disease, but these dogs can also have respiratory signs. They can have epistaxis, sneezing, and less commonly coughing, and rarely pneumonia. Visceral leishmaniasis, it really depends on the immune response, and it starts if the amastigote survives that initial innate response. So it survives the initial smart bombs. Those dogs that do mount a Th1 response, as you can see on the slide on the left-hand corner, they will resist infection. Any of them that mount a Th2 response succumb to disease. So if you really equate this to the military analogy, one arm of the military, i.e. generals in the army versus generals in the navy directing responses, for example, may be more successful than the other in preventing infection. So protection is sort of mediated really through those T cells and the signals giving out the cytokines, interleukin-2, tumor necrosis factor, and interferon. So we want those T cytotoxic responses rather than kind of the, you know, rather than the mission specialists, the B cells that sort of paint the targets to be targeted for destruction. So we really want the cytotoxic T cells to be doing their job. Really, when you're doing a physical exam and you're suspecting leishmaniasis, 90% of animals with visceral leishmaniasis will have lymphatomegaly. So the lymph nodes, if you're feeling for peripheral lymph nodes, they'll be about 2 to 6 times the normal size. So diagnosis of, you know, is made realistically. You can detect the specific serum so we you know, we use our IFAT or our ELISA, and we look at, you know, immunochromatography assays. I'm sort of saying are pretty easy to use. That they provide those rapid qualitative results, but their, you know, the performance isn't really overly optimal. So the disadvantage of serology is that it doesn't detect the presence of the leishmaniasis. Really give us a determination for the diagnosis and for also giving a prognosis. So performance of IFAT and ELISA is dependent upon the laboratory and the cutoff used. So once you select a laboratory to use, stick with that laboratory, so you're always, you know, you don't have a difference in standardization of techniques or a different interpretation. So always use the same laboratory if you're monitoring a dog with leishmaniasis. Typically, you know, cytology of lymph nodes or bone marrow aspirates are really good at detecting the parasite. They, you know, if you may still need to do immunohistochemistry or do a PCR check to detect leishmaniasis. PCR is a great technique. It has a high sensitivity and specificity. And real-time PCR can really quantitate the parasite load for leishmaniasis. You can get false positives with contamination, and it doesn't really review the immunological status of the patient.
So it really shouldn't be performed as that sole diagnostic test, because a PCR will confirm infection, but not necessarily the disease. This is a nice way to effectively diagnose leishmaniasis. It's quite simple. You can use a 22 gauge needle to pass into the rib of the patient you suspect with it. I've used it very easily. It can establish, a diagnosis of leishmaniasis, whether there's respiratory disease or not. Bone marrow cytology can be really useful. It can be done under sedation. You don't need to anaesthetize them. So you go in at that costochondral junction and just run up into the bone marrow, into the rib, and aspirate. And you can. This is actually a DiffQuick, a slide that was done that we used. In a patient that came into the UK. So that's a nice way of being able to actually visualize and see leishmaniasis as well too. So next slide, hopefully. In terms of our treatment, again, we're sort of branching out, because this is, while we do see respiratory disease, it's just a touch base on what you can do. If effectively it's not clear cut, and because we don't see it commonly in the UK, it can get quite confusing. So it can really vary from benign neglect to treatment of renal disease, and you can either use an antimonionate or a miltefosine, and probably miltefosine is what I have used most frequently. Typically, those dogs that come in with leishmaniasis with respiratory disease are going to be either stage 3 or stage 4. So they're going to require some degree of treatment. And those with stage 4 will generally have a protein-losing nephropathy, and they really tend to be at risk for pulmonary embolism. So it's, when you're thinking stage 3, stage 4, this dog seems to have signs of pneumonia, it can be an associative disease that you see. So other protozoal diseases that you can see, Babesia, hepatozoonosis, they're rare, but we are seeing them in the UK, and they are being diagnosed. And so these two parasites, as I mentioned at the start, are often tick-borne, and we probably recognise other disease such as anemia with Babesia and gastrointestinal signs with hepatozoonosis. But they can certainly occur and cause acute respiratory distress and respiratory infection. They can have sequelae that gives respiratory disease. So in Babesia, we see these ARDS, this acute respiratory distress, and it can be a real complication from infection. You have ARDS will have this downstream consequences of activation of cell-mediated immune pathways, endothelial injury, and alveolar flooding. It can have protein-rich edema, and so this edema, this exudative phase, really leads to increased vascular permeability, pulmonary edema, atelectasis, and there can be impaired gas exchange and hypoxemia. And you can often see quite a marked respiratory fatigue, and these dogs often need ventilation. So respiratory failure in people with babesiosis really meets those ARDS criteria. And it's kind of different from other forms of ARDS because it has a delayed onset and a relatively rapid resolution when compared to more typical causes. The respiratory compromise is possibly attributable to ARDS when babesia has been documented in 6% of dogs that had complicated babesiosis, which was found in one study. Only one of these dogs actually went on to recover. So if we start looking further, another retrospective study in dogs that had complicated babesiosis found that 38% of dogs died and 56% had respiratory failure as a listed cause of death. So it is something that's probably under-recognised when we actually see babesiosis, is the effect that it can actually have on the lungs. In Europe, hepatozoonosis is transmitted by the brown dog tick, Rhipicephalus sanguinis, and we can get this transstadial, transmission. The we can have other vectors. We can have Haemophilus, hepatozoonosis felis, and we can have other types of hepatozoonosis. They can occur in cats as well. And these particular patients get an interstitial pneumonia and dyspnea and tachypnea. So it's really important getting a travel history in any particular patient that you're looking at that has respiratory disease or respiratory distress. Come on, cooperate. I don't know why it's not cooperating with me tonight. I don't know that our software is cooperating with each other.
No, we can't see it moving on here either.
Next.
Oh, there we go. It's kicked in.
There we go.
Brilliant. Right.
Yeah. In our more rare protozoal infections, Neospora, it can cause respiratory disease. You can see it reported. It's been reported as a pneumonia, and it's part of an overall systemic disease. This aspirate here is cytology from an 11-week-old West Highland white that had a persistent cough and anorexia. The arrow that you can see, the large arrow, is actually pointing at Neospora tachyzoites, and the small arrow is pointing at two tachyzoites, which are dividing at the moment. So, in terms of diagnostic integrity, it's really quite difficult to differentiate between toxoplasma versus Neospora. And so, diagnosis can sometimes be based on presumptive sort of patient history, clinical signs, positive serology with an IgM or IgG, and you could be looking at serologic assays that you can use either serum or CSF for. Any kind of titer above 1 to 50 is positive for exposure, but most dogs with clinical signs will have serology that'll be greater than 1 to 200. And some will still be seronegative at the time of testing. So it's a challenging disease. It's really infrequent, and it comes back to the positive predictive value of the tests. How high is your suspicion? What other clinical signs did this patient actually have? It's also really difficult looking at oocysts, so you sort of say, well, can we pick up oocysts and feces and do a fecal exam? But they can be really quite morphologically similar to other organisms, one of them being Haemondia. So it often is quite a conundrum to diagnose. So if you see something like this, if you see serology is really the most common and probably the most useful way to get a diagnosis. In fungal respiratory disease, veterinary mycology really is different from human mycology in a couple of different important aspects. So since about the 1980s, we've had immunosuppression, pathological or iatrogenic fungal infection has really been increasing in people. We probably recognise more opportunistic fungi, which are really involved in so many of the human infections. So some of the literature is really different between veterinary and human literature. A lot of the gamut, of veterinary mycology is really, quite unchanged. Aspergillus is the most common that we see, and in cats probably Cryptococcus. And effectively, a lot of the difference between us and human mycology is limited by finances. We don't go into the deep detail of looking at species identification. So really getting that accurate diagnosis can be quite challenging in dogs and cats to know that we're treating correctly. So when the immune system is functioning properly, it will recognise fungi and it will control their growth, and it'll avoid inflammation and allergy. So aspergillosis really represents a spectrum of clinical diseases that really is due to impaired immune response. Invasive aspergillosis is pretty much, confined to severely immunocompromised patients, while allergic forms of aspergillosis really are due to excessive inflammatory response to hyphae, which colonize that sort of sinopulmonary tract. The organisms are pretty ubiquitous in the environment, and they grow slowly, independent, of their hosts. And the saprophytes that we see, so it really depends upon the host in terms of what establishes infection. I see so many people get worried that, oh, my animal has aspergillus, I'm going to contract it. It's really there in the environment, and so it's not necessarily something that will be passed on to either other dogs or cats in the home or to the human unless they're actually severely immunocompromised themselves. So the immune system generally handles most of their mold spores and really prevents, excessive inflammation. The innate immune system of the lungs is usually sufficient to prevent that infection. And so if it's the innate system that fails, that's when we get effectively a sinonasal aspergillosis. Alveolar macrophages constitute that first line of phagocytic host defense within the lungs. And once they've sort of been inhaled and the fungus starts to grow, neutrophils are the first line of defense in trying to prevent the infection from growing. Realistically, for veterinary infections to occur, trauma, unhygienic environment, the anatomical conformation of the skull, or immune disease are the underlying causes. Of note, you see in these pictures of the lungs here, this is the same dog on X-ray as what it is in CT. So you see this fungal granuloma on the left caudal lung lobe. You can see it clearly has an increased sensitivity on CT between the two modalities. It's sort of a bit vague on that radiograph, but it's a lot more prominent on the CT in terms of getting a diagnosis. So the Aspergillus diagnosis, it realistically, it involves that, sinopulmonary tract. It's a reflection of inhalation. And what we do find, imaging really should be considered in patients that have 10 to 14 days of neutropenia, or if the neutrophil count goes below about 500 cells per microliter. You get this persistent or recurrent fever of unknown etiology, any kind of that's basically not responsive to antibacterials. Start thinking potential fungal disease. Serodiagnosis shouldn't just be used alone. You can use a galactomannan assay. They can give false positives if you're giving some of the beta-lactam antibiotics beforehand. And some of the histoplasma can cross-react with as well, because it has a similar cell wall to Aspergillus. But galactomannan detection in bronchoalveolar lavage fluid appears to be quite sensitive for diagnosing an Aspergillus infection. So you could also do PCR, and that can, PCR-basis diagnosis of fungal disease. It's currently investigational, but it's kind of promising in what it might actually offer for us. And if we do get it, it can be quite cost sensitive and really, take us further in what we know about Aspergillus and how we can actually, get across antifungal resistance. So at the moment, galactomannan assays and actually direct culture are probably the most useful in diagnosing respiratory Aspergillus infection. In terms of what we have for treatment, itraconazole is probably the most frequently used drug for Aspergillus. It's an azole, and they work by sort of inhibiting ergosterol synthesis in the fungal cell wall. And you can sometimes use polyenes such as amphotericin B, which also act at the cell wall at a different point. Voriconazole is superior to amphotericin B as primary therapy for invasive aspergillosis, so there's justification to use that in place of amphotericin B. You can get resistance of aspergillus to several antifungal agents because of the failure of therapy. Aspergillus therius is resistant to amphotericin B, and so that might be that might be a cause of failure of therapy if you're dealing with if you're dealing with that particular antifungal. You can sometimes pair cell wall active echinocandins such as capsifungin with amphotericin B formulations, which will also kill off aspergillosis. Probably once you're getting to this point where drugs such as itraconazole or voriconazole have failed, I would probably be recommending referral at that point, because some of the antifungal combinations can be quite challenging in terms of what's going to work and what might actually be, more useful to target the disease. Pneumocystis is, it's been referred to as the fungus that behaves as a protozoan. Most clinical disease has been linked to immunodeficiency, and clinical disease has also been experimentally, activated after glucocorticoid and cytotoxic therapy. It's an opportunistic organism. Realistically, it manifests as an pneumonia, and depending upon the severity of the pneumocystis, it can have variable non-specific respiratory signs that can range from anywhere from cough to tachypnea to dyspnea. So given with those non-specific signs, it needs to be sort of a fast way to sort of get the correct clinical diagnosis can be fairly problematic, and often these cases are referred down the line because they're not responding to treatment. Cats can get pneumocystis, but it tends to be a latent infection due to immunodeficiency. And so it's really been probably most commonly reported in miniature dachshunds and Cavalier King Charles, but also you'll find a fair few number of cases in the literature in Shetland sheepdogs and Yorkshire Terriers. I would have to say by far the majority for me that I've diagnosed have been in Cavalier King Charles. Now, when I couldn't get ahead, I'm skipping across to. So effectively, the entire life cycle of pneumocystis is completed in the alveolar spaces, where all the organisms adhere in clusters, kind of lining the alveolus. And you can get transmission of infection to offspring when you aspirate contaminated amniotic fluid in placental infection. In conditions where you see impaired host resistance or pre-existing pulmonary diseases present, you can get quite a rapid proliferation. And so that clustering of pneumocystis in the alveolar kind of blocks up, and you get this alveolar capillary leakage, and you get a decreased gas exchange. And so it can be quite profound, the cough they actually have, and they just don't tend to respond to common antibiotics. You can effectively long-term eliminate the infection, but by the time you're sort of removing the organisms and all the debris they create within the alveolus, getting on top of the infection can take about 8 weeks. So it's a good couple of months of therapy. You get quite a significant amount of, pulmonary alveolar damage that can actually occur. So given that minimal the minimal inflammatory response and the debris that's created, there's often no fever with pneumocystis, or it's kind of low grade, but you have this cough. They can have weight loss, but still have a really good appetite. And as I say, if you look across the reports in Dachshunds, Cavaliers, and some of those in Shetlands and Yorkies, if they have a, weight loss with a good appetite, cough or dyspnea, is often reported, and they have minimal response to antibiotics and glucocorticoids. So if that happens to you, really consider that pneumocystis may be worthwhile looking at. So in dogs, that diagnosis, to get there, you'll be doing thoracic radiographs, You might see a compensatory emphysema in really severely affected animals. Or you can have solitary lesions, unilateral involvement, cavitary lesions. Some of them will show a spontaneous pneumothorax, and you can get sometimes these lobar infiltrates as well too. So it can be quite confusing and quite have a broad presentation. Some will show this tracheal elevation with a right-sided heart enlargement, and you can get pulmonary arterial enlargement because you get a cor pulmonale, which will be secondary to a real diffuse disease. You can, on bronchiolar lavage, get samples for cytology. You can FNA solitary lesions or do lung biopsies. And to really see the samples, I would always be indicating it to my laboratory saying I'm suspicious of pneumocystis, because they may use special stains such as methamine silver, which can highlight the cysts, or they might do Giemsa stains for nuclei or intracystic sporozytes or trophozoites. Pneumocystis fails to produce antibody titers in immunodeficient dogs, and we don't generally use serology to get a diagnosis. You can do PCR testing on bronchoalveolar lavage fluids, so there are different ways you can get it. But if I had something that was failing antimicrobial therapy, particularly in those breeds, it's what I would be thinking of. It's imminently, the treatment is, it's not horrendous, trimethoprim sulfonamide. It behaves, it's a fungal organism that behaves as protozoan, so it usually responds over 3 to sometimes 8 week period to get rid of that cough. Obviously, when you're using TMS, you're monitoring for side effects on the bone marrow and for keratoconjunctivitis sicca, so they'll be coming to the vet fairly frequently. Moving on to parasitic pulmonary disease, because it's often overlooked, given that we have all these pet care system plans and the frequent provision of anthelmintics. When you start really taking a history on some of these dogs, so many are like, oh, yes, I think my dog took it. Oh, but he does spit out the tablets. So it's often really easy to overlook something that is relatively common. And you can get really heavy manifestations that can cause anything from dyspnea to secondary bacterial pneumonia. And, in areas where you have the wildlife hosts, these really should be considered and always considered as part of when you're taking a history. So, common one, Allura strongylus abstrusus, or cat lungworm. It's really common, particularly in kittens coming from large populations. Snails and slugs are our intermediate hosts, but the cat that often picks up the infection through rodents or birds or eating reptiles or frogs. We pretty much know this one. The parasites are released in the intestine, they penetrate the mucosa and migrate up into the lungs, and the adult worms are found out in the alveolar ducts of the lungs about 8 to 9 days after ingestion. And so the eggs are then laid in their feces about 4 weeks later, and the first stage larvae is found about 6 weeks after they've become infected. And adults can live there for about 9 months or longer. So eggs passed by those adult female worms will hatch in the lungs and pass up the trachea, end up in a coughed up down the intestinal tract and out through the feces. So the infection can mimic feline bronchial disease or asthma, and so it's one of the first things I look for if I'm thinking of a diagnosis of bronchial disease or asthma, is I want to make sure that this cat has been adequately wormed. They can even present with pneumonia, edema, or what looks like pulmonary contusions. And so coughing, dyspnea, open mouth breathing, sneezing, wheezing, anything that kind of looks like feline asthma or feline bronchial disease could actually be a parasitic, Allura strongylus infection. Our diagnosis, well, fecal flotation, a Baumann to look for those, particularly, on either, fresh fecal samples or even sputum. You can pick up the larvae. And you can sometimes pick up larvae by fine needle aspirates if you have a consolidated lesion nearby that you can aspirate in the lung. If you look at the x-rays, they have this kind of diffuse bronchial pattern that you'll see with the orange arrows. This patchy, poor, defined soft tissue nodules sometimes, which are the red arrows you see there. And you might see this right middle lung lobe alveolar disease, which is the yellow arrow that you can actually see on there. And so easily enough confused with feline asthma. The right middle lung lobe here doesn't appear atelectic, but it's infiltrated. So you could potentially aspirate that right middle lung lobe right there. Treatment here, standard worming. I think that when we've got infection of the lungs, fenbendazole at 50 milligrams per kilogram per 24 hours for about 2 weeks is what's used. And often you might start out with a bit of prednisolone to decrease the inflammation, which will do with the death in the lung. And then you can use your standard anti-worming, presentations. The big thing to note is that most commonly that you get your kill of the actual worms when the worms are actually active in the gut. But fenbendazole tends to work really, really well. A lot of common respiratory parasites that we're actually seeing is, well, heartworm is certainly on the rise. We don't have the vector that carries heartworm here in the UK, but with pet travel, it is now being, diagnosed. It can infect dogs and cats. Dogs more frequently succumb to the disease, and the dogs will present, they have a cough, hemoptysis, laboured breathing or exercise intolerance. The infection can sometimes then cause PTE, even DIC, pulmonary hypertension, or congestive heart failure, given that that's where the parasite is living. And it reinforces the importance of knowing travel history and whether prevention was applied before there was a risk of exposure. So if someone's going to one of those countries, they want to put something on to prevent infection before getting there. So again, history taking is really important here. Toxicaris catus, Toxicaris cati and Toxicara canis, they're pretty ubiquitous in the dog and cat populations. So it doesn't really depend upon the animal's lifestyle or diet, but it's pretty much generally the highest infections we're seeing in puppies and kittens, and obviously adolescents. Dogs and cats become infected when they ingest eggs in the environment, raw meat or prey, or sometimes even those paratenic, rodent-type hosts. Again, the eggs excreted in feces become infective after several weeks in the environment, and they can also contaminate the infected, eggs that are in the environment can contaminate soil or vegetables. Hookworm infections are probably most commonly known for diarrhea and blood loss. They can be associated with cough in particular. You get skin penetration in young pups. It follows, migration of the larvae via the blood into the lungs. They cough them up, swallow them, and they mature in the intestine. So, if after migration or through the lungs, they can sometimes even be arrested in somatic tissues such as muscle, fat, mucosa. And these can be reactivated during pregnancy and accumulate in the mammary glands. So this reactivation of these dormant larvae can, occur after you think you've removed all the adult worms from the intestine, or for some other, unknown reason. And it's been come to known as larval leak. So they develop these sort of patent infections. Only realistically hookworms in the intestinal tract are susceptible to deworming. So these patent infections just sit there and wait for an animal to be immunocompromised, and then they cause infection again. And so these ones tend to be quite a problem. And the other, so with Diarrhea immitis and Toxicara, in terms of making a diagnosis, a heartworm diagnosis is made by ELISA serology. So that's an antigen test. which detects protein that's secreted by female larvae in dogs. And you can also visualize microfilaria. You can do a concentration test. False negative tests are pretty uncommon in dogs with low female parasite burdens or in early infection before you get antigenemia, and that can be about 9 months later. Echocardiography can sometimes identify worms, and radiographs will often show these kind of enlarged and tortuous sort of intra and interlobar pulmonary arteries. So on the image here, the ventrodorsal radiograph shows blunted, enlarged, tortuous pulmonary arteries, which hopefully I can show you with these red arrows. And the yellow arrows are sort of showing the enlarged pulmonary trunk. So that would be what you would see with a heartworm infection. Treatments via the adulticide melarsamine, and that's kind of out of the realm of the discussion here. The diagnosis of patent toxocara infection, is commonly done with feces and centrifugal flotation, or less frequently with an antigen test. Toxocara is pretty recognisable as roundworm eggs, and we don't often really do a lot of species identification. You can get negative results with pre-patent infections, and sometimes the number of excreted eggs can be pretty low, so hence collecting over a number of days. Anti-toxocara antibodies can persist for up to 2.8 years, so quite a long time after infection. So using antibody for detecting that infection is not really overly useful. Osleris osleri is an unusual metastrongylid that, again, it has a direct life cycle. They are very small. The males are about 5 millimeters long and the females about 15 millimeters long. They're really tightly coiled and they form tracheal nodules where they live, and they're especially found around the carina. Many of the nodules are spherical and clustered, as you can see on the image here, and those nodules kind of contain those mature adult parasites that, as being quite visible grossly, and they're often the little parasites, these little white things that are coiled within them. Sometimes it's possible to see the tail of one of the female parasites protruding out from the nodule. And the eggs that the females excrete are basically hatched within inside the female, and they pass these larvae and these eggs with larvae in them. The first stage larvae are the infective stage, and they kind of go up the trachea and move into the pharynx. They're swallowed and passed out through the feces, and so this infection is via ingestion of these first stage larvae. You can get bronchoscopy will visualize them. You can do transtracheal washes, zinc sulfate floats. You can also do Bayerman analysis. So they're all ways of actually making the diagnosis. And as you see on the slide, typical standard worming will actually treat them. So Chronosoma volcus, it can mimic allergic respiratory infections, and so it can often be misdiagnosed. And the most effective way to get a diagnosis is to collect first stage larvae and do Bayerman techniques. So the intermediate host is a mollusk, and foxes are really common. So asking if an animal has access or eat fox poo is a part of my history whenever I see a dog with respiratory disease. The females live in the bronchi and they produce larvae that are carried to the intestine by by coughing up and down the trachea, and they then enter into snails where they can develop into third stage larvae. And so dogs can become infected when they eat the snail, and it has basically a pre-patent period of about 19 days. We know that about a single dose of milbemycin is about 99% effective. So it's something that should respond to our standard wormers. And we come to Angiostrongylus. which we're all seeing on a pretty semi-regular basis. It's probably the most common identified respiratory parasite in the UK. Lives in the pulmonary vessels on the right side of the heart of dogs. Its natural end host is the fox. And you can get really variable signs, anything from mild dyspnea, exercise tolerance, to hemoptysis and sort of hemothorax. It kind of has this, you know, scattered and a fairly local appearance of the parasite, which suggests that there's a difference in microclimate in which the intermediate host survives. For the definitive host, the infection prevalence is much higher in foxes than compared to dogs. So about 5 to 56%, quite broad, in comparison to 1.1 to 9% prevalence in dogs. So again, anywhere that foxes live, we see this fairly commonly. Multiple diagnostic tests are available. Fecal exam might be a Bayman test to detect larvae, and you can do a direct fecal smear, which will have about a 54 to 61%, 61% positive predictive value of detecting, or sensitivity of detecting infection. The available evidence suggests that the AngioDetect, it will have high specificity and therefore a high probability of a negative result indicative of the patient not having angiostrongylus. Various studies have examined its sensitivity and specificity, and false negatives can really occur in that pre-patent period and due to really variable and intermittent shedding. And there is a PCR that has been developed to detect infection. It's also not uncommon for coagulation tests to be prolonged. So any kind of breathing difficulty, anything that would suggest breathing plus bleeding disorder, owners that haven't been really good in putting on preventatives, it's one of the things that we're checking for straight away before we're doing a lot more advanced testing. The antiparasites that have really had the most common effect against angiostrongylus are fenbendazole and spot-ons, such as imidacloprid and moxidectin. But you can get common associated bleeding abnormalities, so you might be needing to give plasma and blood products, and you often need to give supportive care. So realistically, the bleeding problems tend to resolve after 24 hours after antiemetic treatment, but the sequela to infection in reality is often a lot longer lived, and some of these are, can be here quite a long time in hospital, needing fresh frozen plasma or anything to stop the prolonged bleeding that we often see with them. Less commonly recognised, Phylloiotes herthae, it certainly is around. You see it in USA, Canada, Europe, Australia, Israel, Japan, commonly report, it certainly gets reported. Most infections are actually subclinical, and for clinical infection, there's usually a concurrent disease. And that seems to be a common theory, that common occurrence with a lot of respiratory disease is there's something concurrent. You often get this dry cough that's triggered by cold air, but more commonly other pulmonary conditions such as distemper, bacterial pneumonia, Bordetella, Streptococcus epidemicus, toxoplasmosis, fungal pneumonia, heartworm, left-sided heart failure, some of the others, eosinophilic bronchopneumopathy, or any of the other lungworms are often associated with this. So luckily, standard fecal floats and anthelmintics will, treat it and detect it. But sometimes, if your patient isn't doing what you think it should be doing, there may be concurrent infection. And so Phylloiotes herthae can sometimes be lurking there in the background, and it's just something to be aware of. Another one, Eucoleus, it has a worldwide distribution as well, and foxes are an important reservoir. eggs are shed in the sputum or feces, and they embryonate in about 30 to 50 days. And so again, they have a paratenic host, so they'll ingest them. It's ingesting the paratenic host. Well, then the larvae will move from the bloodstream and into the lungs. The lungs like to live in the alveoli, and they'll migrate up the air passages and develop. So you can find them anywhere through the bronchioles, the bronchia, the trachea, and so they can cause quite a cough. And some of the patients can get, quite debilitated with it. They can really plug up and cause bronchial plugging. The eggs need to be differentiated from Trichuris vulpus because they look fairly similar, but the eggs of Eucoleus are actually larger. So that's when a parasitologist is quite useful if you have something that looks like Trichuris. It can escape routine preventatives. And so it's reasonable to look for any dog that has tracheitis, bronchitis, or pneumonia to actually consider doing a fecal exam, because this is one of those particular parasites that can escape our standard worming protocols. And finally, we're moving on to viral disease. Our common viral diseases. Given all the recent discussions of COVID and crossing over species, I'm not going to talk about, COVID. And feline herpes virus, while it can cause respiratory disease, tends to be an upper respiratory tract infection. So these are the viruses here that can be associated more with lower respiratory viruses. So distemper, despite years of vaccination, it's still diagnosed as, as a disease. It's an enveloped RNA virus, and it does have respiratory spread. So as we can see here in the diagram, it crosses the respiratory tract to sort of get in through the oral cavity. It reaches our immune tissues there, most likely the macrophages and dendritic cells. These infected cells then carry them down into sort of draining lymph nodes, where they activate sort of T and B cells and cause this primary viremia. The virus is then disseminated through to the spleen, thymus, lungs, gastrointestinal tract, and they're followed by a systemic spread through the entire sort of circulation. So they get that secondary viremia and immunosuppression. Dogs that show clinical signs of disease will often develop a rash, have diarrhea, conjunctivitis, and then we can then sort of see, once it's sort of shed through from epithelial cells, it will enter sort of respiratory and digestive routes. We get a transient fever after 3 to 6 days, and you can get a leukopenia, which tends to be more so the lymphocytes are knocked out, so you get a marked lymphopenia, and that sometimes goes on, unnoticed because the dog hasn't made it to the vet by that stage. They can develop then an anorexia with the fever, and after the fever subsides, there can be a secondary fever, which can sometimes be encountered with serous nasal discharge, mucopurulent ocular discharge, lethargy, anorexia, GI respiratory signs, and it's typically complicated by secondary infections. Sometimes you can get a pustular dermatitis, and encephalitis may sometimes come along with these respiratory signs. So it's really quite a systemic disease. So our other viruses, our adenovirus, our parainfluenza, and our influenza viruses, they kind of have a similar route of infection. So it's sort of oronasal. The adenovirus is a non-enveloped double-stranded DNA virus, and its clinical signs are really associated to damage of epithelial cells, and so it looks like that infectious tracheitis, which we're all sort of fairly common with. Some parainfluenza 3 virus, distemper virus, bordetella, mycoplasmas, strep zooepidemicus, they all can present this way. And so you might sort of see with other viruses that there's this tropism for the respiratory tract, which you sort of see with this infectious tracheitis type presentation. Para-influenza, paramyxvirus and influenza are all pretty much single-stranded RNA viruses, and so they all present with this kind of dry, harsh, hacking cough for 2 to 6 days that you'd see with infectious tracheitis. You might see pyrexia, mucous nasal discharge, pharyngitis, tonsillitis, and so infrequently they can actually go on to develop pneumonia signs with them. When they do get a pneumonia, it's more commonly that there's a secondary bacterial infection that actually occurs. So whenever you see these dogs, sometimes I get referrals because someone said, well, this dog's been coughing for more than 7 days. And sometimes these coughs with particularly influenza virus can go on for 10 to 30 days. So you can have a month of green nasal discharge, cough, high fever, sometimes pneumonia, and often the pneumonia, as I said, is due to a secondary bacterial infection. So how do we go about identifying, the diagnosis of viral respiratory disease? So as with, paramyxoviruses such as canine distemper, and in contrast to herpes virus, it's pretty labile in storage and transport. So you can get false negative results if you don't recognise how labile it is. Rapid diagnosis can be attempted by making immunofluorescent staining of cells from smears or from nasal swabs. And serologic testing can be used by acute and convalescent samples, so similar to our leptospirosis, and they are generally collected about 10 to 14 days apart if you're doing different samples. Traditionally, we do virus neutralization tests, but we are doing ELISAs more frequently. We can get several factors that complicate the use of serologic testing in the diagnosis of parainfluenza virus. It can be due to the endemicity of infection, the persistence of maternal antibodies, routine vaccinations, especially puppies. They can have antibodies in the absence of recent exposure and infection. And so we get reports from many early studies that documented that some animals with antibody titers may not have a serologic response following infection. The timing of the sampling is really important, and the onset of disease is, in relation to the onset of disease can be really quite significant. So stored paired serum samples may be the only way to document some particular types of parainfluenza infection in outbreaks. It's not something that we commonly do, but it's probably what we need to do if we're going to be very definitive in terms of our diagnosis. I am moving across to feline calicivirus. We know it causes upper respiratory tract infection in cats. It can also cause systemic disease. And so there have been some rare occasions where outbreaks of diseases have been reported with really more common pathogenic strains, and they're associated with mutations of the virus that allow it to be established in other different organisms and cells in blood vessels. And pneumonia and hepatitis are two of the most probably frequently recognised. We can sometimes see these virulent strains also cause pancreatitis and skin swelling and ulceration and bleeding from the nose as well too. They're really rare, but when they're affected, up to about 50% of cats can actually die. And so these infections are identified by virus isolation and specifically by PCR. So PCR, molecular diagnostics, PCR and RT-PCR have really become commonplace, both in research and diagnostics. And they're really augmenting and sometimes now really replacing serological and biological methods, microbiology. And so the basis of these PCR diagnostic applications is, detection of infectious agents and discriminating them non-pathogenic from pathogenic strains. And that's often done by the virtue of the genes that are actually present in the bacteria, so quite useful. Conventional PCR really requires information on the target molecule, and then they'll go about designing specific primers to detect the particular bacterium. And so numerous genes may have been targeted for diagnostic potential. The ideal sequences are often mid to kind of highly repetitive in nature, so easily detected. And we also sort of see a high level of sequence congruence between multiple copies of these bacteria. So collecting, samples for PCR really requires us to know which tissues become infected, what's the agent of interest, and where is the pathogen shed. Primers that are actually used are designed on available data, and they'll amplify a single species for an agent, for example, say Mycoplasma pulmonis, or amplify several related agents, i.e. all of the Mycoplasma species. So viral DNA, it's detected by PCR. Primers can be really specific to this targeted sequence of the DNA or virus, and PCR can be used for realistically the diagnostic analysis or DNA sequencing of the viral genome. It has a high sensitivity, particularly soon after infection and even before the onset of disease. So really useful if we use it quite rapidly at the start of infection, or if we have access to something that we can use in-house. Some of the RNA viruses can be sometimes challenging if the primer hasn't been selected, or you can get a false, the right primer hasn't been selected, so you can get a false negative result. So knowing what you're particularly looking for, and knowing if you're sending to an outside lab what primers they're using and they're up to date, is really, really important. You would have to say that PCR is now the preferred diagnostic tool for some of the slow growers, such as Helicobacter, or some of the more zoonotic things or slow growers, such as Mycobacterium or Mycoplasma. So PCR is really useful there. Some of the major limitations in using PCR is making sure you've got that target sequence right, and you're going to amplify the bacteria that you're looking for. And that there hasn't been any morphological or sort of say DNA changes to the bacteria that you're wanting. Some of the DNA polymerases are prone to error because of mutations in the PCR fragments that's generated, and sometimes the PCR can amplify small contaminants as well, which can make our results a little bit more ambiguous. And so it's just sort of being very, very cautious about the samples that we're actually providing to do PCR. So when I had a look at it, and I had a look at the HORIBA in-house PCR, I started sort of circling the number of infections that we discussed even today, and you can pretty much readily use it as an in-house tool. So for speed of diagnosis, for something that's really transmissible infection, you can get that pretty quickly. So despite all the issues tonight, I'd like to sort of thank HORIBA for giving me the opportunity to run through a lot of our infectious diseases. It's a lot of talking, and a lot of things to just either trigger our memory or trigger something that we might now know that we didn't know before. And so hopefully we can detect things now beyond bronchopneumonia. So in final words, I'd like to sort of say that it's not only the challenge of just the patient coming in, but it's selecting the right diagnostic test and determining if it actually has meaning to the patient. And thank you for sticking with me tonight through all the technical difficulties that we've actually faced.
Amanda, thank you so much for the presentation, and thank you to everybody that's attended and stayed with us thus far through those couple of technical hitches that we had in the middle there. So thank you for bearing with us. I certainly think it was worthwhile, and I found it an incredibly useful and enlightening presentation. I know you said just before we started that you knew you were going to run over a little bit, and I think with the technical and with your enthusiasm for the subject. We have run over, so I know that you have said that you're still happy to answer questions, and we have had some that have come in through the questions box on the screen. So if anybody else does have questions that they'd like to submit, please do those now, and we will come to them. But thank you again, Amanda, a really comprehensive walk through respiratory disease, you know, making us think about everything from initial presentation, what does it look like, the benefit of a really good clinical history, you know, and where that pet has been, either locally or internationally. You know, it can make such a difference to where you start looking for things. And of course, something that's really close to our hearts at HORIBA is the quality of the samples that you have. You know, make sure that your sample is appropriate, make sure it's good quality. And you talked about the range of sample types as well, whether that's a swab, a flush, an FNA, or something more involved like taking a tissue sample. But when you're looking for these infectious diseases, obviously we have to look for where they live, and sample quality is key to good diagnostics. I loved as well, on another point, I love the little testing haiku that I saw on one of your slides as well. That just really caught my eye. There was a comment there about haiku, which just lightened it a little bit. So something for absolutely everybody there. So we'll move on to the questions in the interest of getting on. So first question from Sam: in bacterial pneumonia, azithromycin hasn't been mentioned. Does it help with quick resolution?
Oh, does it help with quick resolution? I guess it's kind of a non-answer from my perspective, because it really depends upon whether you've selected it for the right bacterium. Azithromycin can be really useful, particularly in cats, for some of the nasal infections, because you don't necessarily, after your induction phase, the antimicrobial tends to sit in macrophages, so you can span out and give it every few days. So the advantage for me when I use azithromycin, I tend to use it more so in cats when I have nasal infection. I haven't used it very commonly in lower respiratory tract infections, but if I had something that cultured and said it was appropriate to use, yes, I would use it. But I have to say, I don't use it overly commonly.
Okay, that's really helpful. Thank you.
I think that's a bit of a non-answer, but for me, it tends to be based upon culture and sensitivity results.
I think we've covered a lot this evening around the appropriate use of antimicrobials, looking at, you know, what's the right treatment to be used at the right time. And there are things that are warranted in certain cases, but I think the evidence-based approach, if you've got something that isn't responding to basic treatment of the culture and sensitivity, makes a lot of sense if you're able to do that, and helps in justifying those decisions and using those treatments which are or should be really quite restricted. So I think taking away from what you've said is that it can be used but should be used appropriately. You know, in those cases. Okay, the next question. In lungworm, the unlicensed fenbendazole appears first over the moxidectin that's licensed, and after single application, 85% efficacy that increases to 100% efficacy with second application after 30 days. That was quite a lot, and I'm just reading it off the screen here very quickly. So this is unlicensed fenbendazole over moxidectin for use in lungworm. Any comments on that, Amanda?
Yeah, it's a big one. I have to say, when I see Angiostrongylos, generally by the time it makes it to referral, it's quite a severe infection, and I tend to see them when they're needing blood products because their coags are quite prolonged. They may be thrombocytopenic. I tend to be fairly aggressive in my approach, in that I would probably use a combination of both fenbendazole and moxidectin. With fenbendazole, there's still a question as to how many days you actually give it, because you'll see across reports, sometimes it says 7 days, and we've had people treating them out to 21 days. on average, I'm finding that I'm treating for around about sort of 14 to 21 days with fenbendazole, but I'm also treating with moxidectin. Is there anything in the literature that would support that? No, that's just been my experience, and I found that being more aggressive, that I would use a combination of both. I may even use a little bit of steroid, as mentioned, I think in one of the slides, for the first 1 or 2 days as I'm starting to kill off the worms, because I don't want to make the respiratory signs worse. So yes, I know we should be following the cascade, but from I can certainly justify my use in my experience is for these really nasty infections, I tend to use a combination of both. I don't know if that answers the question.
I think that you've alluded to the fact that you're seeing the cases that are the non-standard ones, and are taking very much an experience, an evidence-based approach to your treatments. Of course, you have to. I think realistically, if you had a dog that you had a positive, test result with, that came in that had a little bit of a cough, that was otherwise well, that didn't have bleeding disorders, yes, I would probably use moxidectin, because I know that it's, as a spot on, I know that that it's getting the product, because, you don't have a dog that's refusing to take something in orally. I would then be checking to make sure that I had cleared the infection. If that failed, yes, I'd be moving across to fenbendazole if the moxidectin, if that actually failed. I haven't seen any valuable resistance data to it yet, whether the worms are actually resisting any of the particular drugs at this point. It may be that I haven't seen that in the literature, but certainly nothing that has come out mainstream that I've become aware of. So probably in the early infection, it would be reasonable to use, moxidectin first. Okay, that's really interesting, and to hear about your feedback on the literature as well. I'm sure you're very much across what's current and the responses to treatment. We have another question. This is quite a specific one about an individual case. It's about a rescued cat who'd had a thick nasal discharge, sneezing. He'd had some medication. He was put on a Flexitide inhaler, and it helps. Occasionally he has discharge and sneezing, but he's mostly clear. Any idea what test he should have to get to the underlying problem? If that's something we perhaps need to take offline, then we could support that outside of the webinar.
Yeah, I'm actually more than happy if someone wants to send me an email directly. I'm more than happy to sort of answer and try and give some guidance on that one, because it sounds like I might need a little bit more information in terms of trying to help in that particular case. So, as was said at the start, I work at Hamilton Specialist Referrals, and if an email is sent directly to me here at Hamilton's, I'm more than happy to discuss the case and talk it through with you.
Okay, that's really helpful, and I think a better use of the time, and you're able then to get a full picture of that cat, who sounds like he's been very lucky, been rescued from a hoarding situation, and is in the hands of a very caring owner who wants the best for him. So we are drawing to a close now. If there are any further queries, then please feel free to pop them in the questions box quickly now. So just to thank Amanda again for a really comprehensive presentation and for answering our questions. If there's anything else that springs to mind after this evening, or after you've seen the webinar, or if you're watching back, then you're very welcome to contact us, and Amanda, as she said, will answer questions directly. We can pass on any further queries. If you have interest in the HORIBA products, you can contact us directly also, and we will be at the events on the screen at the Equine Congress in Liverpool in September. We will also have a stand. I don't think I'll be there, but some of the team are going to Madrid in October this year, and we will be at London Vet Show. So please come and say hello if you'd like to. We have our next webinar coming up in September, which is on transfusion medicine. So we're looking forward to that. And if you're registered, you should get an email invitation to join that if you wish. If there are any subjects that you would like us to present on in the future, then please let us know. I don't have any further questions come in, Amanda, so I think that just leaves for me to say thanks again for your comprehensive presentation, all of the detail that's there. We've had quite a few people join us, and I know we'll get lots of people watching that as well. So wishing everybody a very pleasant rest of your evening, and thank you for joining us at HORIBA this evening. Thanks very much.